Welcome back to the deep dive. Today, we are shifting gears. We're moving away from, general curiosity and stepping directly into the fire. We are going into full exam preparation mode.
That's absolutely right. For the next hour or so, this is not a casual browse through the medical literature. This is a high-intensity review session. I really want you to imagine you're a junior rodent. You've got your coffee, you've got your textbooks open, and you are staring down the barrel of the Gujarat University MD anesthesiology exams.
And to help us navigate this, you are stepping into a very specific role today. You are the senior MD anesthesia faculty. You're the one sitting across the table during the Viva, looking over your glasses, just waiting for the perfect answer.
I am, and I'm not looking for fluff. I'm looking for precision. I'm looking for safety. And most of all, I'm looking for a structured, physiological understanding. The topic we're tackling is, well, it's a beast. It is arguably the cornerstone of the entire obstetric anesthesia curriculum.
We are talking about stages of labor and labor analgesia.
It's the triple threat. You will see this as a 20-mark theory question. It is almost guaranteed to appear as a long case discussion, and it will absolutely 100% pop up in the table viva. If you're sitting for your MD or DNB, you simply cannot escape this topic.
So our mission is clear. We are going to construct the perfect audio answer for that 20-mark question. We've pulled from the Bibles of the Field Miller's Anesthesia, Morgan and McHale, Stolting. We've even referenced anatomical guides like Beat Each Rasia, and we've analyzed recent question bank patterns to see exactly what the examiners in Gujarat are asking for.
We have to move beyond just basic definitions. We need to drill down into the physiological mechanisms, the specific nerve pathways you will likely be asked to draw on a mannequin, and of course the anesthetic management strategies that score the highest marks.
Okay, let's get straight into it then. Part A, the stages of labor. Section 1 in our outline is the introduction and exam framing. How do we start this answer? Where do you begin?
You start with a definition. And in an exam, your definition has to be absolutely bulletproof. You cannot just say labor is having a baby.
Right. It has to be precise. Miller defines it specifically, doesn't it?
It does. Miller defines labor as the onset of organized regular uterine contractions.
Organized. Okay.
That result in progressive cervical dilation and effacement.
And I noticed you really emphasized that word progressive.
That is the operative word. It's the key. You can have painful contractions, even regular ones, but if the cervix isn't changing, that is not true labor. That's what we call false labor, or Braxton-Hicks contractions.
And why is this distinction so critical for an anesthesiologist? I mean, isn't that really the obstetrician's problem to sort out?
You'd think so, but no. The timing of our intervention, our entire plan, depends on it. If you place an epidural in a woman who is in false labor, you might actually stop what little uterine activity there is.
Ah, so you could prolong the whole process.
You could stop it then. And then you end up managing an epidural for 24, maybe 48 hours with zero progress. That increases infection risk, it uses up resources, and it's frustrating for everyone. You need to be able to look at the chart, look at the patient, and identify that active physiological change is happening.
Makes sense. Okay, let's break down the first stage of labor. This is section 2, and you've marked this as very high yield.
Extremely high yield. The first stage is primarily the cervical stage. It begins with the onset of those regular, painful, progressive contractions we just defined, and it ends with complete cervical dilation.
Which we all know is 10 centimeters.
Correct. Now, duration is a classic Viva question. In a nulliparous woman, that's someone having her first baby. Morgan and other texts will tell you this usually lasts about 8 to 12 hours.
And for a multiparous woman,
It's significantly shorter, usually around 5 to 8 hours.
Yeah.
But the real exam nuance, the place where you score extra points, lies in the phases within the first stage.
You're referring to the latent phase versus the active phase.
Exactly. And here's where you can really shine by discussing what I call the curve debate. Historically, we used Friedman's curve. Friedman described a latent phase where the cervix dilates very slowly, up to about 3 or 4 centimeters. Then the curve just shoots up. That's the active phase, where dilation happens rapidly, about 1 to 1.2 centimeters per hour.
But that's the old way of thinking, isn't it? Newer data suggests Friedman might have been a bit too aggressive in his timelines.
Right. And if you want to impress the examiner, you mentioned Zhang's guidelines or the updated data in Miller. Modern obstetric concepts suggest that the transition to the active phase is often much slower and happens later, maybe closer to 6 centimeters, not 4.
And why does that matter clinically? What's the implication for us?
Because under the old Friedman rules, if a woman was stuck at 4 centimeters for 4 hours, she'd be labeled failure to progress and taken for a cesarean section. Now, we recognize that a long latent phase can be perfectly normal. It doesn't necessarily mean something is wrong. Mentioning this shows you are not just memorizing old textbooks, but that you actually understand modern evidence-based practice.
Physiologically, what's actually happening to the uterus during this stage? What are the mechanics?
The uterus is doing something remarkable. It's differentiating into two distinct segments. The upper uterine segment becomes the active part. It contracts, it retracts, and it gets thicker over time. It's the engine pushing the fetus down.
And the lower part?
The lower uterine segment and the cervix are passive. They are being pulled upward and thin out by the contracting upper segment. This thinning is called effacement, and it's usually expressed as a percentage. So you'll hear 50% effaced or fully effaced.
Okay, now let's get to the core of the exam question, the pain mechanism. Where is the pain actually coming from in this first stage?
In the first stage, the pain is visceral. This is a crucial keyword. You must use it.
Can you describe visceral pain for us? What does that mean in practice?
It is dull, it's aching, and it's very poorly localized. If you ask the parturient where it hurts, she'll rub her lower abdomen or her lower back with the palm of her hand. She can't point to a specific spot with one finger.
And the cause? What's generating that signal?
Two primary factors. First, you have ischemia of the uterine myometrium. During a strong contraction, the pressure inside the uterine wall actually exceeds arterial pressure, which temporarily cuts off blood flow. It's essentially an angina of the uterus.
Wow.
Second, you have the mechanical stretching of the lower uterine segment and the cervix as they're being pulled open and thinned.
This brings us to the most famous VIVA question in all of obstetric anesthesia, the nerve pathway. I'm standing at the mannequin in the exam. The examiner says, "Show me. What do I trace?"
You must memorize this sequence. It has to be second nature. The nociceptive impulses, the pain signals, leave the uterus and travel via small, unmyelinated C fibers, and they travel with the sympathetic nerves.
Sympathetic, got it. That's a key distinction.
A critical one. They pass through the uterine plexus, then to the inferior hypogastric plexus, they ascend through the superior hypogastric plexus, and finally, they reach the lumbar sympathetic chain.
And where do they actually enter the spinal cord? This is the money answer the examiner's waiting for.
They enter via the white rami communicantes at spinal segments T10, T11, T12, and L1.
T10 to L1.
That is the mantra for the first stage of labor, T10 to L1. And because the input enters the cord at T10, L1, the brain interprets the pain as coming from those dermatomes. That explains perfectly why women feel the pain in the lower abdominal wall, which is T10 to T12, and in the lower back and upper sacrum, which is L1.
So anesthetically, if I am initiating an epidural in early labor, my target is clear. I need to ensure my block covers T10 to L1.
Precisely. You do not necessarily need to block the sacral roots yet. A low-volume activation of your epidural that just covers those lower thoracic and upper lumbar segments will make the patient perfectly comfortable.
But labor is, of course, a dynamic process. It doesn't stay there. We move to section 3, the second stage of labor.
And this is another very high-yield section. The second stage begins at full cervical dilation, so 10 centimeters, and it ends with the delivery of the infant. This is the pushing stage.
What about the duration here?
It's highly variable, anywhere from 15 minutes in a multiparous woman to well over 2 hours, especially in a nulliparous woman with an epidural. We often allow it to go longer these days, provided the fetal heart rate tracing is reassuring.
And the physiological events, they change here quite dramatically.
They do. The fetus is now actively descending through the bony pelvis and the soft tissues of the birth canal. This descent triggers a neuroendocrine reflex called the Ferguson reflex.
Okay, explain that for us. That's a good term to use in the exam.
It is. The mechanical stretching of the cervix and the upper vagina by the fetal head sends a neural signal up to the posterior pituitary gland. The pituitary responds by dumping a massive surge of endogenous oxytocin into the bloodstream.
And that creates a feedback loop.
A classic positive feedback loop. More stretch leads to more oxytocin, which leads to stronger contractions, which leads to more descent and more stretch. It's the body's way of getting the job done quickly.
Now the pain, it changes character completely at this point, doesn't it?
It shifts. And this shift is the absolute exam core concept. You still have the T10L1 visceral pain because the uterus is still contracting, maybe even harder than before. But now you add a new type of pain. Somatic pain.
Somatic, meaning sharp and well localized.
Exactly. This is no longer a dull ache. This is a sharp, burning, tearing sensation. It comes from the physical distension of the pelvic floor muscles, the vagina, and the perineum. The baby's head is literally stretching the skin and fascia to their limits.
And this pain travels on a completely different set of nerves. It does not travel via the sympathetic chain.
Correct. It travels via the pudendal nerve.
And the nerve roots for the pudendal nerve are, this is a must-know.
S2, S3, and S4. The classic mnemonic is S2, 3, 4 keeps the pelvic floor off the floor. You have to know that.
This leads to a very, very common clinical scenario, which is also a classic Viva trap. You have a patient with a working epidural. She was perfectly comfortable, pain score 0 during the first stage. Now she is fully dilated, she starts pushing, and she is in severe, uncontrollable pain. The obstetrician looks at you and says, "Did your epidural fail?"
And your answer is no. This is called sacral sparing. The epidural was working perfectly for the T10L1 visceral pain. But the local anesthetic solution, for whatever reason, hasn't spread caudally downward enough to block the very large sacral nerve roots, S2, S3, and S4.
So how do you manage that in the exam scenario? What do you tell the examiner you would do?
You don't panic and you don't pull the catheter. You demonstrate your understanding. You say, this is likely sacral sparing due to inadequate caudal spread. Then you describe your intervention. You sit the patient up. Gravity will help the heavy, hyperbaric-like local anesthetic solution sink down toward the sacral roots. You might give a top-up dose of a slightly more concentrated solution. This shows you understand the anatomy and the physics of the blockade.
Brilliant. Okay, let's quickly cover section 4, the third stage of labor.
This stage begins with the delivery of the baby and ends with the delivery of the placenta. It's usually pretty quick, maybe 15 to 30 minutes.
And the physiological elements here are all about hemorrhage control, right?
Absolutely. The uterus contracts down very firmly, like a clenched fist. This dramatically reduces the surface area of the placental attachment site, causing the placenta to shear off the uterine wall. Then, the living ligatures, the crisscrossing muscle fibers of the myometrium, contract around the open spiral arterioles to stop the bleeding.
Now, we often think of this as the cool-down phase. Everyone's happy, the baby's out, but you flag this in our notes as a potential hemodynamic danger zone.
For a healthy woman, it's usually fine. But for a woman with significant cardiac disease, the third stage is probably the most dangerous time of the entire pregnancy.
Why is that? What's happening so suddenly?
Two massive hemodynamic shifts happen almost instantly and simultaneously. First, there's a huge autotransfusion. When the uterus contracts down from the size of a watermelon to the size of a grapefruit, it acts like a sponge being squeezed. It pushes about 500 to 800 milliliters of blood out of the uterine circulation and back into the maternal systemic circulation.
That's a massive volume bolus delivered in seconds.
It is. Second, you have caval decompression. For months, the gravid uterus has been sitting on the inferior vena cava, obstructing venous return. The moment the baby is delivered, that obstruction is gone. So all that blood that was pooled in the legs and pelvic veins suddenly rushes back to the heart. Venous return skyrockets.
So you have a surge in preload from both the autotransfusion and the caval decompression. Cardiac output must spike.
It does. Cardiac output can increase by as much as 80% over pre-labor values within just a few minutes of delivery.
So if I have a patient with, say, severe mitral stenosis,
it's a potential disaster. A stenotic mitral valve acts like a bottleneck between the left atrium and left ventricle. It cannot handle that sudden, massive surge in preload. The blood backs up into the pulmonary circulation, and the patient goes into flash pulmonary edema.
So while the obstetrician is high-fiving the family and the baby is crying, the anesthesiologist needs to be laser-focused on the monitors and the patient.
100%. In a cardiac patient, you manage the third stage with extreme caution. You might need diuretics ready. You definitely avoid giving any extra fluid boluses with your oxytocin. Knowing this physiology is what saves lives.
That wraps up Part A beautifully. We have the anatomy and the stages down cold. Let's move to Part B, labor pain and physiology. This is Section 5 in our outline.
Right. And the exam question here is usually phrased as, discuss the physiological consequences of unrelieved labor pain. Or, to put it another way, why should we treat labor pain?
Aside from the obvious humanitarian reason that it hurts a lot.
Correct. The examiner is looking for the pathophysiology of pain. Unrelieved, severe pain is a massive physiological stressor that affects almost every single organ system.
Let's start with the respiratory system. What happens there?
Severe pain causes hyperventilation. The mother breathes too fast and too deep. This washes out huge amounts of carbon dioxide, leading to maternal hypocarbia and a subsequent respiratory alkalosis.
And based on the Bohr effect, which we should all remember,
that respiratory alkalosis shifts the oxygen-hemoglobin dissociation curve to the left. And a left shift means an increased affinity of hemoglobin for oxygen. In simple terms, mom's hemoglobin holds onto the oxygen much tighter and refuses to release it to the tissues
And to the fetus.
and to the fetus.
Yeah.
So step 1, maternal pain leads to fetal hypoxia, but it gets worse. The pain also triggers a massive sympathetic surge. The body is flooded with catecholamines, epinephrine, and norepinephrine. These are potent vasoconstrictors. They clamp down on the uterine arteries.
So you're reducing blood flow to the baby even more?
Exactly. So now the fetus is getting less blood flow, and the blood it is getting is holding onto its oxygen too tightly. It's a double whammy that can lead to fetal acidosis. This is why we say that effective labor analgesia is actually a form of fetal resuscitation.
That is a fantastic line for the exam. Analgesia is fetal resuscitation. It reframes the whole purpose.
It does. And beyond the fetus, that catecholamine surge also increases maternal oxygen consumption and cardiac work. In a patient with preeclampsia or limited cardiac reserve, the tachycardia and hypertension caused by pain can precipitate myocardial ischemia or heart failure. So treating the pain isn't just nice to do, it's a medically indicated stabilization of both mother and baby.
Okay, that's a powerful argument. Let's move to the solution. Part C, labor analgesia. Section 6 is the overview.
Right. The ideal labor analgesic, it doesn't really exist, but we have goals. The ideal technique should satisfy the 3 Ps of labor. It shouldn't negatively interfere with the powers, the uterine contractions, the passenger, the fetus, or the passage of the maternal birth canal.
And what about the timing? This is a classic myth that we really need to bust for the exam.
Yes, there is a persistent old myth that if you give an epidural too early, say before 4 centimeters of dilation, you will stop labor in its tracks.
And that's not true.
It is not true. High-quality evidence, cited in Miller and in multiple Cochrane reviews, shows that the early initiation of neuraxial analgesia does not increase the risk of cesarean section or prolong the first stage of labor.
So what is the correct exam answer for when do you start the epidural?
It's simple and patient-centered. You start it when labor is established and the mother requests pain relief. That's it. It is a decision based on patient comfort and the clinical picture, not a number on a ruler.
Perfect. Section 7, systemic analgesia. This usually means opioids, right?
It does. Let's first talk about pethidine, which is also known as meperidine. You will see this in older textbooks and maybe in older question banks.
But we need to be critical of it in a modern answer.
Very critical. In the 2024 exam answer, you should immediately list its significant disadvantages. Pethidine is metabolized in the liver to normeperidine. Now, normeperidine is an active metabolite, and it's a neurotoxin. It causes CNS excitation, tremors, and can even precipitate seizures in both the mother and the baby.
And it has a long half-life in the baby.
A very long half-life. It readily crosses the placenta and can hang around for over 20 hours in the neonate. It's a major cause of floppy baby syndrome and neonatal respiratory depression. So while it is still used in some resource-poor settings, it is far from an ideal agent.
So what's the modern standard for systemic analgesia if an epidural is contraindicated?
Remifentanil. Without a doubt, this is the gold standard for patients who cannot or will not have an epidural.
And remifentanil is an ultra-short-acting opioid. Why is it so much safer for the baby?
Because it's metabolized by non-specific plasma and tissue esterases. It's broken down in the blood within minutes, so it doesn't accumulate in the fetus at all. We typically use it via a PCA pump, a patient-controlled analgesia device. The mother presses a button when she feels a contraction beginning.
But there's a huge caveat here, a major safety warning.
A huge one. Remifentanil is an incredibly potent respiratory depressant. It can cause maternal apnea within seconds of a dose. If you are going to use this, you must have one-to-one nursing care, continuous SpO2 monitoring, and supplemental oxygen immediately available. You cannot just hang the bag and walk away. That is a negligent act.
Okay, message received. Now let's talk about the main event. Section 8, regional analgesia, specifically the epidural.
This is the exam favorite. The question will be something like, describe the technique, pharmacology, and advantages of labor epidural analgesia.
We know the basic anatomy, usually the L3, L4 space, using a loss of resistance technique. But let's focus on the pharmacology. We do not use the same surgical concentrations of local anesthetic that we'd use for a C-section.
Absolutely not. This is the whole concept of the differential block. The goal is to block the pain fibers, but to spare the motofunction fibers.
We're aiming for the so-called walking epidural.
Exactly. And to achieve this, we exploit the difference in nerve fiber sensitivity. We want to block the small, unmyelinated C fibers that carry pain signals, but we want to spare the large, heavily myelinated A-alpha fibers that control motor function.
So what concentration of Bupivacaine do we actually use to achieve that?
We use ultra-low concentrations, think 0.0625% to 0.125%.
That is incredibly dilute compared to the 0.5% or 0.75% we might use for a surgical block.
It is. And to make it effective at such a low dose, we almost always add an adjuvant. Usually that's a lipid-soluble opioid like phenol, typically at 2 micrograms per ml, or sometimes sufentanil.
And how does adding the opioid help?
It's all about synergism. The local anesthetic works on the sodium channels in the nerve axon and the nerve root. The opioid works directly on the mu receptors in the substantia gelatinosa of the spinal cord's dorsal horn. By attacking the pain pathway at 2 different points, we can use much, much less of each drug to get a profound analgesic effect.
And this preserves the pelvic floor muscle tone.
Which is absolutely vital. The baby's head needs to rotate internally as it descends through the pelvis. The gentle resistance of the pelvic floor muscles is what guides that rotation. If you completely paralyze the pelvic floor with a dense motor block, the head might not rotate properly, leading to malposition, dystocia, and a higher chance of an instrumental delivery.
What are the absolute contraindications? The things where you just say no.
Patient refusal is always number 1. Medically, the big one is coagulopathy.
What's the cutoff for platelets that you'd state in an exam?
It's a bit of a gray area, and institutional policies vary. But for exam purposes, a safe answer is that most authorities agree if the platelet count is below 75,000 to 80,000, the risk of an epidural hematoma is unacceptably high. You should also mention uncorrected severe hypovolemia and, of course, a skin infection at the injection site.
Let's move on to Section 9, the Combined Spinal Epidural, or CSE.
Ah, yes, the needle-through-needle technique. This is a more advanced skill, but you need to understand the principle. You identify the epidural space with your 2-Wahi needle, then you pass a long, thin spinal needle through the epidural needle, puncture the dura, and inject a very small intrathecal dose of local anesthetic and/or opioid.
Why go to all that extra trouble? What's the benefit?
One word: speed. A spinal dose works in 2 to 5 minutes. An epidural can take 15, 20, even 25 minutes to set up properly.
So if a multiparous woman comes in at 8 or 9 centimeters dilation in agony and you think she might deliver soon?
An epidural might be too slow. She might actually deliver before it has time to work. A CSE gives her immediate, profound relief from the spinal component. And then you have the epidural catheter in place to maintain it, extend it for a repair, or even convert it for a C-section if needed. It offers the best of both worlds: rapid onset and flexibility.
Great. Briefly, Section 10, other regional techniques.
You should be able to mention the pudendal nerve block. This is usually performed by the obstetrician, not the anesthesiologist. It's done via a transvaginal approach, aiming for the ischial spine as a landmark. It's useful for the second stage, specifically for a forceps delivery or for suturing a perineal tear. But crucially, it does not relieve the pain of uterine contractions.
And what about the paracervical block?
You could mention it mainly to dismiss it as a historical technique. It involves injecting local anesthetic into the fornices of the vagina to block the Frankenhauser plexus. The reason it's fallen out of favor is its high association with fetal bradycardia, sometimes up to 15%. It's just not considered safe in modern practice when better alternatives exist.
Okay, let's move to Part D, anesthetic and obstetric implications. Section 11 asks about the effects of analgesia on the progress of labor.
We touched on this earlier, but to summarize it perfectly for the exam, you should state the following 4 points. 1. First stage. Modern epidurals do not prolong the active phase of the first stage of labor. 2. Second stage. Epidurals do prolong the second stage on average by about 15 to 20 minutes. This is mainly due to a reduced urge to push. 3. C-section rate. Epidurals do not increase the overall cesarean section rate. 4. Instrumental delivery. This is the controversial one. Epidurals may slightly increase the rate of forceps or vacuum delivery, especially if the motor block is too dense and interferes with maternal pushing efforts.
Very clear. Section 12, complications. This is marked very high yield. What is enemy number 1?
Hypotension. Without question, it is the most common and most immediate side effect we deal with.
Explain the mechanism for the examiners. Why does it happen?
It is caused by sympathectomy. The local anesthetic in the epidural space doesn't just block sensory nerves. It also blocks the sympathetic chain, which runs from about T1 to L2. This causes profound vasodilation, primarily in the venous capacitance vessels of the lower limbs and the splanchnic bed.
So all the blood just pools in the legs and gut.
Right. Venous return to the heart plummets. Cardiac output decreases. And because the placental circulation is not auto-regulated, it's a low resistance, maximally dilated system-maternal hypotension leads directly to fetal hypoperfusion and potential fetal distress.
So what's the management? The examiner asks, the blood pressure is 80/40, what do you do now?
You need a crisp, three-pronged attack. 1, left uterine displacement. Immediately ensure the patient is not lying flat on her back. Tilt the table or place a wedge under her right hip to relieve aortic valve compression. This is step 0.
You need to rapidly administer intravenous fluids. Co-loading, which is giving fluids rapidly as you are placing the block, has been shown to be more effective than preloading.
This is a key update for modern exams. Older texts always said ephedrine. Current guidelines and the correct exam answer is phenylephrine.
Why the switch to phenylephrine?
Phenylephrine is a pure alpha agonist. It directly constricts the dilated vessels and raises SVR. Ephedrine is a mixed agent that also crosses the placenta and can stimulate beta receptors in the fetus, increasing fetal metabolism and potentially leading to fetal acidosis. Phenylephrine has a much better fetal acid-base safety profile.
What about the dreaded PDPH?
Post-dural puncture headache, the wet tap. If you accidentally puncture the dura with a large 16 or 18 gauge epidural needle, there is a greater than 50% chance the patient will develop a severe disabling postural headache due to CSF leakage. It's a major complication.
Okay, section 13, special situations. Let's talk preeclampsia.
Students often get confused here. They think, this patient has critically high blood pressure. Maybe I shouldn't be doing a procedure that can cause hypotension.
But the epidural is actually the preferred technique, isn't it?
It is absolutely the technique of choice. It's beneficial. It stabilizes their labile blood pressure by blunting the catecholamine surges from pain. It can even improve intravenous blood flow. However, you must navigate the big Viva trap, thrombocytopenia.
Right, as part of HELLP syndrome.
Exactly. You must check a recent platelet count before you even think about putting a needle in the back. You cannot go in blind.
In cardiac disease, this seems very complex.
You have to categorize the lesion in your mind. For lesions where tachycardia is dangerous, like mitral stenosis or aortic stenosis, an epidural is excellent because it prevents the tachycardia of pain and stress. But for lesions that are dependent on high systemic vascular resistance, like Eisenmenger syndrome or severe pulmonary hypertension, an epidural can be lethal.
Because if you drop the SVR with the sympathectomy,
You increase the right-to-left shunting of deoxygenated blood, bypassing the lungs entirely. The patient becomes profoundly hypoxemic and can suffer a cardiac arrest. In these very rare, very complex cases, we might use narcotic-only intrathecal techniques or titrate our local anesthetics with extreme caution and full invasive monitoring.
we are in the home stretch now. Part E, exam integration. How do we structure this whole thing in a written answer? Section 16 mentions diagrams.
You cannot pass a 20-mark anesthesia paper without a good, clean diagram. You need 2.
The pain pathway. Draw a simple cross-section of the spinal cord. Draw the uterus. Draw the sympathetic chain running alongside the vertebral bodies. Clearly label the afferent fibers entering at T10-L1. Then separately draw the perineum and the pudendal nerve entering at S2-S4. This shows the dual pathway.
The block level. Draw a simple outline of human figure. Show that for stage 1, you need a T10-L1 blockade. For stage 2, you need to extend that down to T10-S4. And then for a potential C-section conversion, you must show the block extending all the way up to T4, which is the nipple line, to ensure a pain-free surgery.
Section 15. Common Viva traps. We've discussed sacral sparing. What about the test dose question?
This is a classic safety question. You've placed your catheter. The examiner asks, how do you know it's in the right place? You must describe the test dose. The standard is usually 3 milliliters of Lidocaine, 1.5%, with adrenaline, 1.200,000.
And you're looking for 2 different things, right?
2 things, and you have to describe both. 1, intravascular injection. If the catheter tip is in an epidural vein, the 15 micrograms of adrenaline will cause a brisk, noticeable increase in the maternal heart rate, usually by about 20 beats per minute within 30 seconds. You must state that you're watching the ECG monitor. 2, intrathecal injection. If the catheter has gone too far and is in the spinal fluid, the 45 milligrams of Lidocaine will cause a rapid, dense motor block within 3 to 5 minutes. You must state that you will ask the patient to lift their legs. If they can't, you are in the subarachnoid space, not the epidural space.
Excellent. A final exam tip to wrap it all up. Section 17.
When you conclude your written answer or your Viva, always bring it back to safety. Use the phrase, a multidisciplinary approach. Mention that you would communicate closely with the obstetrician and the neonatologist. Mention that you would monitor maternal hemodynamics and fetal heart rate continuously. These are the buzzwords that tell the senior faculty, this candidate is a safe pair of hands.
Let's just recap the absolute highest yield points for the drive home.
Okay, here we go. 1, first stage pain. It is visceral. The pathway is T10-L1, traveling with the sympathetic nerves. 2, Second stage pain, you add somatic pain. The pathway is S2, S4 via the pudendal nerve.
This is the gold standard. Use a low-dose Bupivacaine, like 0.0625% to 0.125%, plus fentanyl to achieve a differential block and preserve motor function.
This is your enemy. Prevent it with left uterine displacement and fluids, and treat it aggressively with phenylephrine.
The epidural is beneficial, but you must check the platelet count first. 6. Cardiac disease. Know your lesion. Epidurals are good for stenotic lesions where tachycardia is bad, but dangerous for shunts where a drop in SVR is bad.
Expertly summarized. To our listener, as you're imagining yourself in that exam hall, take a deep breath. You have the structure now. You have the knowledge.
Go and find those diagrams in BD Cherasia or Morgan and Mikhail right now. After you listen to this, actually draw them out. Visualizing those nerve roots is the absolute key to locking this entire topic into your memory for good.
Good luck with the Gujarat University exams. You've got this.
Go smash it.
Thanks for listening. We'll see you on the next deep dive.